and
Okay.
somebody else has to edit it. And you'll just look at me.
Okay.
Okay.
My name is Dr. Carol Kruse, and I'm a senior investigator and director of the Joan S. Holmes Biotherapeutics Laboratory at the Burnham Institute for Medical Research.
Now spell all of that. No, I'm joking. You don't have to do that. I'm joking. I'm joking. Let's talk a little bit about your research. Give me the essence of the research that you're currently doing.
Well, I've been in a research lab about 30 years, and the research area of focus has been on brain tumors and using immune and gene therapies for treating those brain tumors. So we have various culture and in vitro models to use for their study, and as well, we've taken some of our things to the clinic in the past.
Where are you now, Carol? Where is the research today, and where is it that you wanted to go? Go ahead.
Well, we've been studying immune cells for about 30 years. And we have tried all sorts of different types of immune cells that are present in the body. And in 1995, we landed on one specific type of cell. It's a T cell called a cytotoxic T lymphocyte. And we have it directed towards some proteins or antigens that are on the surface of brain tumors that do not happen to be on normal brain. And so we train these T cells in culture to react against this set of proteins that happens to be on the tumor but not on normal brain cells. And then they are actually from a different individual than the patient. And they're directed against their transplantation antigen, and in order to get around any problems that they would pass through the blood-brain barrier, they're actually put right into the resected tumor cavity when the neurosurgeon debulks the tumor.
Mm-hmm. So I didn't understand any of that. So look at me as your audience so that we have to really get it down to actually did understand it. But I'm thinking, let's try to simplify it a little bit more.
Okay.
Okay, I know you did already, but let's try that one more time.
I sure did.
I know you did.
You might start with saying that the fundamental is the difference between that tumor protein that's on tumors but not on normal brain, and the immune cells are the only ones that can really traffic through and crawl through normal tissue.
Okay.
And get the really bad part about this cancer is that it weaves through all the normal brain, so you can't ever really
Okay.
capture it all. There's always something left behind.
All right.
All right, let's try that again.
Okay. So
remember, we edit all this.
All right.
And it's going to look brilliant.
Okay.
Okay.
So my laboratory is interested in the study of a certain type of brain tumor known as a glioblastoma, or a set of tumors called gliomas. And these gliomas have properties that make them highly difficult to treat by just having a surgeon come in and resect them alone. There are always infiltrating patches of these cells that go through brain. And so my laboratory is concentrated on the study of T cells. They're a type of immune cell that normally do immune surveillance in the body. So they're always trafficking through tissue looking for something that they don't like. So we actually can manipulate these cells in the laboratory and train them to recognize certain proteins that happen to be on the surface of the brain tumor cells that aren't on normal brain. We also get around the fact that the patient who might be immune suppressed is treated with this immune cell that comes from a healthy, unrelated individual. So we're using T cells that are healthy and active. They aren't from the patient himself.
So it's kind of a search and destroy. You know, you're searching out the bad
certainly
cells,
is.
and you're aiming at only the bad ones and not everything in general.
Right. I think the selectivity that you need in the kill that you get for brain tumors is so much more important than it might be for other tumors that are located elsewhere in the body. Because if you start using cells that aren't selective and you kill neurons, they may not come back. They may not regenerate. So it's very important that you don't do or have any collateral damage to these normal brain cells, and you try to restrict your kill to the brain tumor.
Tell me a little bit about the work you did with, what's Tracy's last name? Tracy?
Tracy.
Megan Sherry.
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 I was gonna say Tracy Stacy.
Mm-hmm.
That whole era of the research where 6 people, or was it 6 who were initially?
6 were treated in Colorado.
You might start by talking about they were compassionate release, and what is
No,
that
they
mean?
weren't.
Oh, they weren't.
Okay,
That's very different.
all right.
I,
Well, tell
The
me about,
pediatric patients were compassionate release because they didn't fulfill the eligibility criteria. But we
okay.
actually had a phase 1 clinical trial that we conducted in Colorado at the University of Colorado Health Sciences Center years ago. Dr. Kevin Lillihei was the clinical director of that study, and there were several other neurosurgeons in town working with us on this so that we could treat patients at different hospitals. And we treated a total of 6 patients with this particular type of immune T cell. And lo and behold, these patients that we were able to treat, the FDA had mandated that they would have failed all conventional therapy. That means that they often had 1 or more surgeries. They had their course of radiation. They had chemotherapies, sometimes of multiple types. Some of them even had gamma knife before their tumors recurred and came back. So
And
their
prognosis
options.
was?
Their prognosis was very poor. At that point in time, it's a choice between hospice care or entry into an experimental protocol, such as the one that we offered. So we would have expected, had they gone off to hospice, that they might have lived maybe 3, 4, 5 months. So out of the 6 that were treated, 3 of them actually did quite well. And 1 made it 40 months from the time of entry into the immune therapy protocol out before he died, and 2 others are alive today and have had no other therapy since for their tumors. So we find this truly remarkable. They've done much better than they might have under other circumstances.
And this told you what?
That we should keep pursuing the clinical study and testing of this particular immune cell population. And that's exactly what we're going to try to start up here now that Colonel Holmes is supporting.
Tell me how important it was to you, Dr. Kruse, to get that funding from Colonel Holmes, to get that crucial help when you needed it the most.
Well, it's been very difficult. It's been a few years back since we treated this patient population. We needed adequate follow-up. So because they were grade 3 glioma patients, we needed a longer time to tell whether we were really off that bell curve. And we did something for these patients than what might have been expected as just perhaps an outlier. So at that point in time, we went back, and cellular therapy was considered to be fairly expensive by the National Cancer Institute. Many other considerations, have gone into leading science in a different direction in the field, small molecule inhibitors, signal transduction molecules, that type of thing, so that we kind of fell by the wayside when we went back to the review panels.
But it wasn't just the science of the methodology, it was also the type of cancer you were working on, wasn't it? I mean, if this was
Right.
breast cancer or prostate cancer or any of the other, I guess, more publicized cancers that impact large number of people, if this same type of results were in that population, you'd be overflowing in grants right now, wouldn't you be?
Well, I think the fact of the matter is that this is actually considered an orphan disease by the FDA. There are only 20,000 patients in the U.S. diagnosed with this type of brain tumor a year. as opposed to maybe the nearly 100,000 metastatic brain tumors. But the funding for this type of research really falls under the purview of NINDS at the National Institutes of Health. It's the National Institute for Neurologic Disease and Stroke and Trauma. And in essence, you might think it is a cancer. The National Cancer Institute should be funding this research too. And of course, there are many other cancers that are there in many more patients. And so you're sort of falling between the cracks as to who should be funding this. And generally what has happened is that you'll get dual funding, and both the National Cancer Institute and NINDS will do a 50-50 take on some of these grants.
Do you sometimes feel like just standing on the top of the hill and screaming at the top of your lungs, hey, I've got something that just might have an incredible benefit, maybe just to a small number of people, but you know, those are people with families and lives and all that. Is it get real frustrating for you?
Well, it can at times, but I think you just learn to be persistent in this field. You keep trying and you keep working at it. Something will give at some point. Luckily, Colonel Holmes stepped up to the plate.
Talk about persistence.
Beautiful.
I think Colonel Holmes probably wouldn't want his name mentioned, though.
Well,
You know, he only wanted the Jonas Holmes thing mentioned, but he didn't want to be tracked down.
and he won't be to the general public. He may well be to Cindy Kimmel. I think he would want to.
And remember,
Okay.
we have edit control of things. Before anything goes out, we'll run everything past everyone, and
All right.
it's the beauty of editing. You can pull stuff out.
Okay.
Yep. But I'd like, unless you have another idea that's better, I'd like to segue into what you said about persistence, and then have you go back and talk about what got you away from your former field of study, your husband, and your work since there, and the motivation to be that persistent, if that's.
Yeah,
if
because
Okay.
this
Okay.
hasn't been an easy road to travel, funding-wise for
And-
you.
and
So why
also-
keep going?
When we're talking about private donors, we're not talking about institutes. It's all very personal. And this is gonna be edited out, but you know, we see it every time we talk to Colonel Lee. It's a very personal thing. And that resonates with what Linda says. It makes sense when you think, why has this lady who's so brilliant been so persistent?
It does take a lot of persistence, doesn't it?
Yes.
Now
Start-
stop playing
start
with
with
your mic.
Oh.
Did you always start out looking at brain cancer?
Yes.
Oh,
Tell
okay.
us
You
about
want to
your
know?
journey.
Okay.
What was the motivation
What
to
was the
switch?
motivation for your persistence?
In 1985, my 35-year-old husband was diagnosed with a glioma, and I had a 1-year-old at home at the time. And he was one of the first persons to be put into a immune cell trial out of 4 places in the United States that were doing these types of things. They were the wrong cells to use, or at least not the best ones to use. I think we've landed on a better population right now. But he actually did live 2 years with an unresectable tumor in the brain that was about 5 or 6 centimeters. So when he was diagnosed with this, I met a lot of other patients in his support group, and I just decided, you know, somebody has to do something about this, and this is the way I could contribute.
And so where has this road led you? Tell me a little bit about, over the years, where has this road
well,
led you?
this is the 3rd or 4th clinical trial that we've been working on. We were working with some cells at the Wistar Institute people. We were using a cell line called TAL 104, which is allogeneic. You aren't going to like that.
You already know.
Okay,
But
well,
personally, this is
this
taking
is
you-
about the 3rd trial, and I think, you know, from the indications of what we got before, and a very small number of patients would at least like to confirm and not prematurely adopt this approach. Not prematurely let this clinical trial go by the wayside without confirming the findings. It's real important to test this population again.
There's something in you, though, that tells you there's something there, isn't there?
I think so. They really are quite remarkable cells. You can see how well they do in culture against a variety of different tumor types. You can see that they kill multiple tumor cells very quickly if they come into contact with them. You can see that they produce cytokines, which are growth factors that can make them proliferate and do bad things against these tumors. So I believe in them.
What, you want to take a drink of water there?
Yes, thank you.
There you go.
Can't do that.
Maybe it might be worth talking about by contrast.
Okay,
Radiation.
we'll get there, we'll get there.
By what?
Okay. You know, traditional forms of
Oh, okay.
treating
Sure, years
cancers.
ago I used to lecture at the University of Colorado, and I probably sent some of these medical students into shock, but I would say that the whole basis of cancer therapy today is that you try to kill the tumor off before you kill the patient. In essence, the chemotherapies, you know, are like dumping poison into people, and they're non-specific. They hopefully kill the tumor that's growing much more quickly than normal cells. And radiation is almost like French frying cells. So up in the brain where selectivity is real important, you need an immune cell because they are selective. They can offer that very specific kill of the brain tumor cell without causing damage to normal.
This cell almost has a personality of its own, doesn't it?
Oh,
I
it
mean,
does.
it almost has an identity. It's got a, I can
Well,
almost see it.
it's a memory T cell. So they're the types of T cells that circulate in the body for a long time. It's the same type of cell that you get when you get a tetanus shot or polio or you get some virus. It has a memory, and they can actually circulate in the body for many, many years and have recall and then go back and regrow in numbers effective if they run into that foreign agent or body or virus again.
What are you hoping down the road that this research, in a perfect world, if what you suspect is true, and
I would love to see this therapy take a place.
it's okay, stop
I
it.
would love to see the therapy take a place in the treatment armamentarium for brain tumors, where shortly after patients receive their surgical resection, you can actually get to immune therapy before you get to radiation and or chemotherapy, before you start destroying other immune cells with these other non-selective, non-specific treatment agents.
So it's the first line of defense.
So it would be more upfront than it is right now, which is it's the last resort. Now, if we can actually prove that this is doing something, I think we can start moving this up, because there has been some precedent set now for the FDA letting clinicians start testing these things in newly diagnosed glioma patients.
Wow.
And the beauty, you might talk about the beauty, is that if you started with newly diagnosed, you can also use that in conjunction with standard of care, so that you might say that in your own words, that the next
For
step-
the higher grade gliomas, you actually might be able to get this so that you're intercalating some immune therapy while they're receiving standard of care radiation therapy with temozolomide.
Step. Can we go back to temozolomide? If I could have you look at her and say, if I were to say to you, what is the latest, greatest new therapy in treating brain tumors?
Okay.
What happened and what was the result of that?
Well,
How
I've been in
much-
this business a long time, and we've been trying to increase the survival of patients for many, many years. It was generally expected that the median lifetime of a patient diagnosed with a glioblastoma was 12 months. The latest incremental advance has been that a chemotherapeutic agent called temozolomide has come along. And what happened was that the median survival went from 12.1 months up to 14.6. So we got a 2 or 3 month increment in survival that was actually statistically significant enough to make the insurance carrier take over the cost for that therapy.
That's big.
That was big.
Why? Tell me why that was big. What does that mean to the patient?
Well, I think that the agent was probably less toxic than some of the other chemotherapies that were received. So the side effects for taking that medication were a little better, and there was just a very small incremental increase in survival.
But what did it mean to their pocketbook and to the affordability of treatment? You said something about the insurance company now stepping in.
Well, that's what standard of care therapy means, is
Uh-huh.
that actually the insurance company will pick up for the cost of that therapy. It has proven benefit for that patient population.
And what had to happen before they got to that point? I mean, what?
There were huge they went from phase 1 to phase 2 to then phase 3 trials. So large cohorts of patients were treated to actually prove that that statistical increase in survival was real.
And when you measure that against what you want to do with your research, where are you now? What needs to happen before this can get to that point?
I would actually like our cells to show that there are very few side effects. We want a non-toxic therapy in essence. Of course, I don't mind if you see a little short-term transient toxicity, but something that's quite tolerable for the patient, and then offers good quality survival time, because that's what's so very important. I don't think we have illusions that we're going to cure this disease at any point in time in the near future, but if we can buy that patient some good quality survival time, it's worth it.
Well, if you talk to the patient in Colorado, she will tell you it is worth it.
Well, I would hope so.
Yeah.
And I'm very pleased to think that, she went along, got married, and had a child, and is enjoying her life.
Right. And anything that we've missed that we need to talk about? Do you want to talk more about the need for additional funding?
Well, I want to get back to that, but if we start back at the fact that this is uniformly, if you're talking about grade 4 gliomas and glioblastoma multiforme, universally fatal disease, but it's an orphan disease. Only 20,000 people in the U.S. and about the same amount in Europe get this disease. What is the implication for what you're doing today in this study for pediatric brain tumors and possibly metastatic
Okay.
tumors?
Okay.
All right.
That's good.
Well, right now we do have grants funded by the DoD, the Department of Defense, and we're actually studying using these cells because they're able to crawl through and find perhaps metastatic foci in the brain. So I have a study where we're looking at infusing these cells into the brain for treatment of breast cancer, metastatic to the brain. And this could be applied to most anything at late stage. I mean, you don't meet too many melanoma patients who don't have metastases to the brain at death, or lung cancer or whatever. Those that have advanced malignancies generally have brain metastases.
Talk to me a little bit about the implications for pediatric patients.
Well, I guess a lot of people don't really know this, but brain tumors are very significant health problem in pediatric patients. It's the second leading cause of death in children. And it's possible that we might be able to treat brain tumors in children with these cells.
What's the implication of that versus what they have to go through now?
Yeah, what is
The
traditional
developing
now?
brain.
Oh, well, I tell you, it's heartbreaking because the radiation needed in the doses to be effective against these tumors that you can apply, say, to an adult brain, cause all sorts of cognitive and developmental problems in these children. So you can't give radiation in doses that are therapeutic to be a good agent to use for treatment of these. And in addition, they use many different chemotherapeutics in children. They may throw 6, 7, 8 different kinds of chemotherapy agents at these pediatric tumors.
And commonly what happens to children when this kind of treatment is done? And what?
They're very resilient. Somehow, you know, they get through it, but it's
Can it cause
going to
permanent
have some,
damage to them?
absolutely. Both to children as well as to adults. You'll see cognitive deficits in these patients. It's probably to adults a little bit more frustrating for them because I think they know that these once very sharp people aren't as sharp anymore, and they know it's happening to them, whereas children might not be so aware of that type of thing. But it's something that we need to work on.
There's a real urgency to your work, isn't there?
Well, there certainly is when it comes to that particular patient population. If you have them look at this, you say, you bet it's important. They want people to work at it.
We tend to look at the numbers a lot. We tend to say, 100,000 people get this type of cancer and, 50,000 people get that. So it's better to treat the masses as opposed to treating the lesser. But
Right.
when it comes down to it, these are 20,000 people who have families, who have lives, who have children. Talk to me a little bit about that, about how these are individuals, they're not numbers.
Well, they are. It's, I guess, to be expected that numbers drive issues and the money. And I don't know what you want me to say here.
I'm not sure. I think that
Well-
we need to personalize it more, that we need to remember that this isn't just research happening in a
Okay.
laboratory.
All right.
These are real people in real lives.
We
Some of
have
it
used
outside
these cells in
prison.
Colorado to treat pediatric patients by compassionate waiver. We actually had a little girl who lived 2 doors away from us in Colorado. And she had a brain tumor, and we got a compassionate waiver to treat her. This was a little girl that was in my son's class at school. And it was a real heartbreaker. She was a real fighter. But she did participate in this study. And we hope that we offered, some little bit of survival more than she would have gotten, and it was appreciated. I know her parents appreciated it tremendously.
Was it a kinder type of therapy too, so that the time she had left was easier, was kinder?
Well, I can't answer that. I don't have the control,
Yeah. I
okay?
hear you.
But
You know,
the pediatric neurosurgeons in Colorado were quite cooperative, and we treated a little boy with gliosarcoma. He had been a leukemia patient years before, and from the radiation treatment he received for his leukemia, he actually developed a gliosarcoma, a brain tumor. And then we had to treat him. The little girl had an ependymoma, and we treated her with these alloreactive CTL.
Wow.
And you, like I say, you don't have the control, so you don't
Since
know
you don't
what
know
the
it,
benefit truly
yeah,
was.
You don't know. But it was
But-
go ahead,
what
Ann.
happened? Do you know the outcome?
She died.
But how many months?
Part of the problem is you need to get to patients sooner.
Okay.
And we were treating the grade 3 recurrent glioma patients. We're the ones that did better. I felt that our glioblastoma, our grade 4, our high grade primary malignant brain tumors were harder to treat because we needed 3 weeks to prepare our cells. And in that time, we know these tumors can double or triple in size in a month's time. Once